Hey guys, really quickly, we're going to walk through some of the kind of core skills and pathologies that we're going to see in the first half of this module. Module 1, we're talking about respiratory and neuro. So we're going to break this up into a few videos. This first video is just going to be on the assessments, respiratory and neuro, and I'm just going to hit the highlights as we go through. All right, so I'm doing this Rick Mercer style, so anyway. Respiratory assessments. So for both respiratory and neuro, all of the assessments we teach, we follow our basic format. Scene assessment, primary survey, ask questions, so OPQRST ample, so evaluate chief complaint and medical history, then move on to a physical exam, we make up our differentials, and then we come up with a treatment plan. So we'll start with respiratory, I'll work through that whole process, and then we'll do it again for neuro. So respiratory assessment, we've kind of done this before in module 1, but just to review, we do that scene assessment. We're looking for signs of like tripoding, working to breathe, blue in the face, cyanosis, might even see some agitation as they can't breathe. And we move to that primary, looking for that chest rise and fall again, a good airway. In that primary assessment, we can throw on oxygen, and you're probably going to need oxygen in your respiratory patients. Shooting for a SAT of 94 to 99. COPDers are a little bit different. Those guys you'd want a little bit lower, 88 to 92, depending. Remember, your carbon monoxide patients or smoke inhalation, they might have a false high. So anything like that, environmental or exposure-wise, just give them oxygen anyway. All right, we move through our evaluating chief complaint. We're looking for chief complaints of like shortness of breath, maybe some chest pain that goes with it, could pivot to cardiac, hyperventilating, tightness in their chest, those kind of situations. Evaluating ample for our past medical history. Again, ample, straightforward. We're looking for some risk factors, so like smoking, exposure to environmental pathogens, recent pneumonias or frequent pneumonias, again, listed in our assessment sheets. And we're also looking for some relevant history, things like asthma, COPD, lung infections, interstitial lung disease, lung trauma, anything kind of affecting the respiratory system. Excellent. Moving to our head to toe. So I'm just going to hit the key highlights. We're looking for cyanosis, obviously. We're looking for pursed lip breathing, signs of accessory muscle use. So we're thinking shoulders, belly breathing, chest or intercostal retractions, maybe even some subclavicular inhaling. Again, should all fit with that posture. Get down to the chest. We want lots of lung sounds, so really take your time and get into that good lung assessment. We can think about percussion, so looking for dullness versus hyperresonance to help find consolidations of fluid versus air pockets, so tension pneumothorax comes to mind. We can also start looking at the shape of the chest. COPDers sometimes get a bit of a barrel chest, kind of pokes out. It's because they've been air trapping for so long, their body starts to change physically. Moving down to the rest of the body, again, belly breathing. There's no real changes until we get to the extremities. Looking for cyanosis, good cap refill. Fingers sometimes club when we have respiratory patients. And then do the back as well. For lung sounds, the big ones we're listening for would be wheezes, which is going to come into the pathology video we'll do a little later. Crackles, and you can also get absent or diminished breath sounds. Excellent. Differentials, so we're thinking things like asthma, COPD, PE, CHF could kind of come in there as a respiratory one. Anxiety, hyperventilation, pneumonia, all great differentials. Moving to treatment, oxygen, some treatment for respiratory. We're going to look a lot at Ventolin, Atrovent, so those puffers, either MDI or neb. We could be looking at epi for our croup patients, especially peds. IM epi for that near-death asthma patient. We could hit, pressure. Words are hard. We could give them some pressure. So CPAP, BiPAP, positive pressure. And we might need to get more aggressive and intubate to get those higher pressures. All right, we won't do neuro in this video. We'll just stick to respiratory. Good stuff.